Okay, Bismillahirrahmanirrahim. Assalamu alaikum, everybody. On behalf of Parsa HealthNet Echo Pakistan, it's my pleasure to welcome all of you to this extraordinary meeting. And I'm extremely grateful to my colleagues, my friends who have actually made this possible. We have amongst us uh, some world-renowned hepatologists and GI endoscopists who are gonna teach us about liver and COVID-19 and also about GI endoscopy in this time. It's a pleasure to introduce Professor Raj Reddy, who's with us, Professor Bilal Hameed, and Dr. Mustafa Arai, who are amongst the speakers. And amongst the panel of experts in Pakistan, there are a lot, but Professor Altaf Alam is here from hepatology side, Professor Saeed Hameed, and Professor Zagam Abbas. Um, Dr. Saad Khalid Niaz, Professor Gyasun Nabi Tayyab, and Khalid Hassan will be joining also. Well, I can see Khalid now from Florida. Good to see you, Khalid. Um, just a few housekeeping announcements before I start. I won't be taking a lot of time. And Professor Sanjeev Arora will be joining in about 60 minutes from now. So before I hand over to our team in United States, uh, uh, we have kept all of you muted. It was important because sometimes there's a lot of disturbance when the talks start. If you have any question, you have this group chat function. You can write down your question and forward it to us. And at the end of the talks, we will be taking this question to the experts. Uh, if you have any problem regarding the sound quality, it's a good idea to keep your video off. It sometimes improves the voice you are receiving. Please ensure not a lot of people amongst our home are logged into the Wi-Fi at the same time, because that also disturbs the quality of reception that you guys are receiving. So before wasting any time, it's my pleasure to introduce Professor Raj Reddy from Pennsylvania. Raj, it's over to you. I would just like you to say a few words about yourself, about the panelists, and then we start the presentations. Yes, Raj.
Thank you, Asad. Indeed, it's our pleasure to be here. I'm Raj Reddy. I am a hepatologist. I'm the director of hepatology and the medical director of liver transplantation at the University of Pennsylvania. And I, along with several hepatologists, have been working in an unprecedented manner to try and get the knowledge about COVID-19 and the liver to the community in general. And Dr. Bilal Hameed, who's here today with us, who's an associate professor of medicine at the University of California, San Francisco, has been participating in these endeavors. We also have Dr. Mustafa Arain from UCSF. He's an associate professor of medicine, and he's an endoscopist with us, and he will bring on a different dimension of GI endoscopy and related matters to this webinar. At the outset, I want to emphasize that this is something that is seen in the Western world. Some of it, most of it may be applicable to your practice. We want to have this as a bidirectional endeavor. And so clearly, we really would like to have input from the participants and the senior professors about the challenges pertaining to your region, and as to how best we can help take care of the patients and others at risk for this infection. So with that, I'd like to move forward with some introductory comments. Now, this is the AASLD COVID-19 working group on behalf of myself and Bilal would like to acknowledge their contribution to this effort. Next slide. So there's something fundamental that we need to recognize and appreciate. There are a lot of terms that are used, but one has to be careful in how you use these terms. I know loosely we call it coronavirus. So the virus is different from the disease. SARS-CoV-2 is the virus, and COVID-19 stands for coronavirus disease, and 19 represents 2019. So when someone is infected without the disease, strictly speaking, we should call it SARS-CoV-2 infection, and the disease is represented as COVID-19. Now, this has similarities to SARS-CoV virus, which we saw in the early 2000 period. Fortunately, it did not go around the world like this infection has gone. It causes an infectious respiratory disease, and I pointed out this is COVID-19. SARS stands for serious acute respiratory or severe acute respiratory syndrome. It all began in December 2019 when a cluster of pneumonia cases were seen in Wuhan province in China. Then subsequently, it was identified as a novel coronavirus. Then the first fatality was reported in January 2019. And then the first case outside China was reported in Thailand. And then in January, WHO declared this as a global health emergency. And in March, WHO declared this as a global pandemic. And of course, we have had several challenges in the US, particularly more recently, while this has been identified as an ubiquitous global infection. Next slide, please. So briefly speaking, the symptoms are of fever, fatigue, dry cough, while diarrhea and nausea can be reported by these individuals. There's also a unique symptom of loss of a sense of taste has been described. And then these patients could have anorexia, myalgia, dyspnea, expectoration. Incubation period could be up to 14 days. On an average, is 4 to 5 days. And then about 80% of cases have been characterized as mild. This is based on Chinese Center for Disease Control and Prevention. About 14% were described as severe, and about 5% were characterized as critical, where they had respiratory failure, septic shock, and multi-organ failure. Next slide. This is what is going on in the US, and I live in Philadelphia. Mustafa and Bilal are on the West Coast. Fortunate for them, the bubbles are not large. The size of the bubble and the density of the bubble describe the number of cases and the number of severe cases as well to some extent. And worldwide, this is a report as of the 4th from a website that is monitored and populated by Johns Hopkins University. Worldwide, there have been over 1.1 million cases. About 60,800 deaths have been reported. In the US, there have been about 7,100 deaths, with about 750,000 cases. And then we recognize now New York and the greater area of New Jersey and Connecticut have become the epicenter. And in the US, as of yesterday, they reported 30,000 new cases per day. We are on the verge of the bubble in Philadelphia. We are preparing for a surge, and we certainly expect to see a good number of cases over the next 2 to 4 weeks. Next slide. So the populations at risk, the key thing is those who have comorbid condition have a higher fatality rate. If you were to look at case fatality rate, it's highest among those with cardiovascular disease. This is again from China. This is Chinese infectious disease information. About at 10.5%, diabetes case fatality rate around 7, hypertension 6, chronic respiratory disease about 6%, and then etc. If you were to look at age, that's important. Those between the ages of 70 and 79 had an 8% fatality rate, and those greater or equal to 80 years of age had a 15% fatality rate. Now, the CDC has identified individuals at a higher risk for severe illness. These are people aged 65 or older, those living in a nursing home or long-term care facility. And conditions that would apply to people in Pakistan would, like anywhere else in the world, would be those with chronic lung disease, moderate or severe asthma, serious heart condition, and obesity. Now, we do have an epidemic of obesity, and I suspect there is obesity in Pakistan, and then you need to be aware of that. There is obesity, tremendous obesity in the Middle East, like Saudi Arabia, Kuwait, etc. And what you also have to understand is, apart from diabetes and renal failure, those with liver disease have also been identified as being at high risk, something that we need to be aware of. So with this kind of background, I'd like to pass it on to Bilal, who will just give you all an overview on some of the strategies that we would need to adopt while addressing patients with liver disease. And it's a spectrum of liver disease, including liver transplantation as well, although liver transplantation may not be as applicable, broadly speaking, in Pakistan. So Bilal, take over.
Thank you, Raj, for excellent introduction. Thank you. Assalamu alaikum, everyone. So as Raj just mentioned, my topic today, which I will be discussing about the liver, is mainly the data from our document of ASLD working group. I would encourage to go on the website and download the document. There will be an update coming up next week. I want to talk about the effects of SARS-CoV-2 on the liver. Briefly, patients who have liver disease, cirrhosis, and hepatocellular cancer, and then management or immunosuppressive agent. And lastly, medication management of patients who have COVID-19 disease. So I wanted to get some idea about and start with a case presentation. So this is a patient we recently saw at UCSF, 54-year-old male with no prior history of liver disease or cirrhosis. He was admitted with COVID-19 disease and had worsening shortness of breath. He was in the ICU but not intubated. On presentation, his liver enzymes showed ALT of 200 and AST 150. Bilirubin was normal alkaline phosphatase. He did not start any new medications or alcohol. So the question that comes out, and most of the thing that we all need to ask, how common is elevated liver enzymes or liver biochemistries in patients with COVID-19 disease? And what workup is needed in this patient? So what we know, as Raj has mentioned, that SARS-CoV-2 and SARS-CoV, which is the initial SARS virus, does share 82% of their genome sequence. And even in the SARS epidemic that we saw in early 2000, about 60% of patients had some reported liver impairment. So far, the data from China and Spain and Italy that we have seen that the incidence of elevated liver biochemistries in hospitalized patients with COVID-19 ranges anywhere between 14 to 53%. So this patient that we saw in our hospital, it's not surprising that he had elevated liver enzymes. So what we know is that about this disease, that SARS-CoV-2 does bind to ACE2 receptor to gain entry into the cells. Mostly found beside is the biliary epithelial cell. So there is some discussion about the direct toxicity of the liver with this virus. We already discussed that elevation of liver enzyme in hospitalized patients are seen in 14 to 53%, and it does correlate with the severity of COVID-19 disease. If you have a mild disease, your liver enzyme may not be elevated or only mild elevation. However, in severe COVID-19, we have seen much higher elevation of ALT and AST. There is one case report of acute liver injury that has been described. However, there is no report of acute liver failure so far. Also, severe COVID-19 disease is uncommon in children and less likely to be associated with elevated liver tests. One of the other factors that we are seeing is that low serum albumin is a marker of severe COVID-19 disease. What we don't know is that why the liver biochemistries are elevated in patients with COVID-19. As discussed, that there may be a direct viral effect, but it can also be secondary to immense inflammatory and immune response that happen in these patients. There are concerns for drug toxicity as these patients are on multiple antiviral agents. And there is also much higher AST level and some CK level that we have been seeing in recent studies, suggesting a thought about a muscle injury that can happen with COVID-19 and can cause elevated liver enzymes. So based on what we have learned so far, our recommendation from AASLD is that we do recommend testing for hepatitis B and hepatitis C in patients who have COVID-19 and elevated liver biochemistries. But we do avoid any unnecessary imaging unless there is a clinical suspicion, like you worry about thrombosis, biliary obstruction, or cholangitis. The goal is minimal movement of these patients to prevent the spread of the virus. Patients who has COVID-19 can be on some investigational medication when we talked about what are the new medications that have been studied in the Western world and other countries. Also, we don't want patients to assume that, that there is an autoimmune hepatitis flare-up of rejection who are patients coming in with elevated liver enzyme and COVID-19, because it can cause elevated liver enzyme with COVID-19 alone. We do evaluate patient with COVID-19 elevated liver enzyme because normally patient with children with COVID-19 does not have elevated liver enzyme or severe disease. So if a child has elevated liver enzyme with COVID-19, that should undergo the normal evaluation as any other children with elevated liver enzyme. So what about the patients who have liver disease, cirrhosis, or hepatocellular cancer? So we all know that asymptomatic patients can contribute to SARS-CoV-2 spread. And I think that's one of the main reasons the SARS-CoV-2 is different than a lot of other competent and immunosuppressed patients can contribute to that spread. In fact, patients who are immunosuppressed have increased viral shedding. There is no evidence so far with the data coming out that patients who have stable chronic liver disease like hepatitis B, hepatitis C, NASH have increased susceptibility to SARS-CoV-2 infection. What we don't know is that patients who have hepatocellular cancer are at increased risk of severe COVID-19. There are reports of other cancers and patients can have, but so far we have not seen hepatocellular cancer as one of the factors that patients have risk of severe COVID-19. What we also don't know is what are the effects of SARS-CoV-2 if that happen in patients with chronic liver disease or decompensated cirrhosis patient. There is a paper just came out in liver transplantation from Italy that they have about many decompensated patients in their practice and did not have significant or severe SARS-CoV-2, but we are waiting more data from other countries to see whether these patients, if they get COVID-19, will have a worse or severe effect. So our recommendation is pretty, all these recommendations is based on how to prevent the spread. So we do recommend severely limiting outpatient visit to only urgent issues or clinically significant liver disease, someone who has recent decompensation with jaundice or very high visits or telemedicine. If you see these patients in the clinic or any patient, we do recommend staggering the patient arrival times, and patient can be roomed immediately. In Pakistan specifically, there are a lot of friends or family members who comes in. You have to limit how many people are coming to the clinic with you, and you can have for symptoms of fever or recent exposure before they enter into the clinic space. Again, you need to prevent the spread. Also, if you have a patient with chronic liver disease, hepatitis B, or any other thing, you have to make sure that they have adequate supplies of their medication. What we are recommending, at least 90-day supplies. There are few liver transplant programs, but in US, we are recommending suspending liver donor a living donor liver transplant, except for very indication of acute liver failure or anything that we see that patient has very high MEL score. Again, it's an individual decision of the transplant centers. Lastly, if someone is on hepatitis B and hepatitis C medication, if you already started, it is completely fine to continue these medication and you don't need any adjustment. And lastly, Mustafa will kind of talk about it, but from our Liver Society and Joint Society guidelines, we are recommending to cancel all elective or non-urgent procedures. And specifically from liver point of view, this includes liver biopsy and fibroscan. If you need to do a liver biopsy to rule out rejection, or if you need to do it for autoimmune hepatitis, that is perfectly fine to do it. If someone has, what are the recommendations for hepatocellular cancer? So we do, you need to do still surveillance imaging in these patients who have cirrhosis or hepatitis B or prior history of HCC. But in certain patients, arbitrary delay of 2 months is reasonable and may be necessary based on how much. Again, the point is that patients have less exposure. However, if you do have patient with hepatocellular cancer, these are considered more urgent and because of prevention of the spread on progression of HCC. So we are recommending that you still need to proceed with their hepatocellular cancer treatment. Again, these are individual decisions based on what the risk of the cancer and how big they are, but we do still recommend that this can be, you still should proceed with the treatment. Now, before I talk about the immunosuppression, this is a patient that we recently had a message from one of my patients. She's a 32-year-old female with history of autoimmune hepatitis, which was diagnosed 2 years back. She had some history of compliance in the past and had few flare-up, but now in remission. She is currently on 5 milligrams of prednisone and azathioprine 75 milligrams. So the one question we've been recently asked many times from different physicians and also for the patient, that during this COVID-19 pandemic, whether we need to decrease her immunosuppression or not. So what about the patients who are on immunosuppressive agent? What we know about the immunosuppressive agent is that the effect of immunosuppression in COVID-19 so far is not well established. It is very early or too early to know if immunosuppressed patients are at increased risk of severe COVID-19 disease. However, if we do reduce or stop the immunosuppressant, we can cause even more problem. That patient can have a flare-up of autoimmune hepatitis like my patient which I described. Or if someone has a liver transplant or any transplant, you can precipitate an acute rejection. So based on that, our recommendation is patient who does not have COVID-19 disease, we are not recommending to routinely reduce the immunosuppression. So we are recommending to continue the same medication as they are. However, things are a little bit different that if a patient on immunosuppressive does develop COVID-19 disease, if you do develop a patient, we do consider minimizing the dosages if they are very high dose prednisone, like someone with a recent acute rejection or autoimmune hepatitis, but you have to maintain a dose to avoid adrenal insufficiency. You consider reducing, but not stopping the immunosuppression, and especially if the patient has lymphopenia, fever, or pneumonia, which is attributed to COVID-19. The other question, especially in the US, what happens if someone has alcoholic hepatitis? And we are recommending that you need to use a caution in initiating prednisone immunosuppressive therapy where the potential benefit might be outweighed. However, if you do have a patient with autoimmune hepatitis, that patient will need treatment for their autoimmune hepatitis, and you have to make sure that the patient understands the risk and benefit. So lastly, my last section of my talk is what is the medical management of patient with COVID-19 and the potential drug-drug interaction, especially if someone is on transplant medication or other medication. So I think we all are aware there are no approved medication or drugs for COVID-19. There are a lot of investigational or experimental drugs that have been studied. They have some possible role to it. Things that we are using in the United States are remdesivir, IL-6 receptor blocker like tocilizumab or sarilumab, hydroxychloroquine or chloroquine and azithromycin. There is data about nitazoxanide, convalescent plasma. There is a paper from JAMA about the patients, 5 patients who had, 4 of them had improvement, which was severely sick into the ICU. And favipiravir, although not available in the United States, but is a flu medication in Japan. However, it is very important to know that some of these medications can cause direct liver toxicity, especially remdesivir and IL-6 receptor blocker. And in the clinical trial in the US, that if you have elevated ALT, AST greater than 5 times upper limit of normal, it's an exclusion or stopping criteria. Also, you need to look at the safety of these medications if you have a patient with liver disease. The drug-drug interaction, cardiac arrhythmias, prolonged QT interval, and other form of cardiac arrhythmia is a big concern, and you have to be very cautious if someone is on these medications. In Pakistan, I know hydroxychloroquine and azithromycin has been talked about a lot, and we have seen prolonged QT interval with our patients. So what we know about the medication use of COVID-19 is the randomized controlled trial of lopinavir and ritonavir, which was published in New England Medical Journal, had not shown any clinical benefit. There was no mortality benefit or viral suppression in this. But these medications, which are HIV medication, are potent inhibitor of cytochrome P450 system and can increase the dose of their immunosuppression. There's a lot of talk about, because the virus does work on the ACE receptor, but European Society of Cardiology and other societies now recommend its continuation of your usual antihypertensive therapy like ACE inhibitors or angiotensin receptor blockers. The recommendation is that so far the data and evidence does not support the use of lopinavir and ritonavir for COVID-19. If a patient is on chronic ACE or ARB inhibitor, they should remain on them even in the setting of COVID-19. The most preferred analgesic agent, as most of us are aware, are acetaminophen, less than 2 grams per day. If some of the patients in the US, especially in these medications or clinical trial, it is very, very important to monitor their liver chemistries, especially with remdesivir or tocilizumab. So this is an excellent website if you do have patients who are in immunosuppression post-transplant, although not that many, but if you are managing these patients, the Liverpool Drug Interaction Group has an excellent site with every medication or class of medication. I'm just showing the data of immunosuppressive medication that because of the cytochrome P450 system, that the tacrolimus or other, even with hydroxychloroquine and chloroquine, you can increase the level of cyclosporin and tacrolimus and sirolimus. So you have to pay attention to these and look at this website. So this is the end of it. I would do encourage people to go on the AASLD website for the clinical insight document. We will have a complete or updated version next week. It's just very complete. And also on April 7, 2000 of next Wednesday, we do have a AASLD webinar, which is free registration, no membership is needed. And we'll be talking about some clinical cases and rapid fire journal club. I would be excited to see more participants from Pakistan joining these webinars, as AASLD does monitor which countries are, and that will be very important. And now I will hand over to Dr. Mustafa Arai for his part of liver COVID. And Mustafa, you can share your screen. Thank you.